So I am going to look at the midwifery education overview. Now, excuse me, I have talked extensively about a lot of issues regarding midwifery education, so I'm not going to repeat a lot of that, and I have only got 15 minutes, so I will obviously condense it. Now, I've actually put it into three main issues that I'm going to talk about. I have written an article that you'll find on the MMF website, really, that's related to these three issues, just to sort of explain a little bit more. Now, this is very topical. I've had this in, I've mentioned it quite a few times, and it's about the rise in cesarean section rate. I am not saying it is a bad thing. I will say that all three of my children were born by cesarean section. However, I did try. I was induced for 2 days. Luckily, they did pelvimetry then. I have a small pelvis, and so apparently, believe it or not, my inlet is too small, and so I would have died. So all I can say is cesarean section has its place. It is absolutely important, and it is life-saving. What I will say is that we have seen a trend. And the trend is that this is a rise in cesarean section rate, and for many units, I believe it's tipping over the 50%, sometimes higher. Now, when we used to talk about normal childbirth, and I have been in midwifery for some time, and it was talked as normal childbirth. And the reason it was normal is because it was the usual, typical, and expected birth. That's what normal means. The majority presents. So if the majority present, that makes it normal. So therefore, if cesarean section rate is now outstripping spontaneous vaginal birth, is this a new normal? So it's just something that, to think about. This is where we're going. When we looked at midwives attending women in childbirth, that is our protected function and title, is that we care for labouring women during childbirth. If it is a planned cesarean section, there is no labour. That's okay. There is no labour, so therefore is a midwife going to be there? It's a fear, and I'm just putting it, but there is a potential. And actually now, for the intrapartum stage, arguably more doctors than midwives are attending women at birth. When you're looking at staffing, and staffing in maternity units uses different tools to look at it. Many use the birth rate plus, and they look at the birth rate plus rate, which is births to midwives. And that's anticipating that midwives are attending these women in childbirth. If that's not going to be the case, this is going to actually alter the number of midwives on the labour ward and arguably the skill mix. Student midwives still need 40 births. Where 40 came from, we've had this discussion. I'm not even going to go into that today. But it has been 40 for some time. It is an accepted number, and it is in the ICM and obviously in the NMC proficiencies and standards. So 40 spontaneous vaginal births for student midwives are getting increasingly difficult for student midwives to achieve. And as LMEs, I used to work at Hull as LME. As LMEs, we used to sort of discuss at length the 30-20 option that is there in the standards. That's not an easy option, because that's actually 50 spontaneous vaginal births that student midwives have to see. If they're not going to see that many because of the rise in cesarean section rate, because if 50% plus are cesareans, then we have the instrumental births on top. And it's looking at, are we going to have student midwives extending the programme, and so therefore reducing student numbers in the long term. This could lead to a problem just going forward. I'm just raising it. So that is an impact on pre-registration programmes. The thought of reducing the number of births that a student has to have has been thrown around and talked about. But do we feel that students are confident and competent after 40? This is where the discussion rises, why 40? But if we feel that there is still some question mark if somebody is competent and confident after 40, would we want to reduce that? And if so, by how many? All of these are absolutely profound discussions that need to have, because the impact is actually significant. And I've also brought in the role of the midwife, obviously with intrapartum care, but also I have to put in postnatal care and preconception care and contraception. This is all things that midwives did, and yet very few actually still do this. And we need to look at our role and our scope of practice, because it seems to be disappearing. My second issue is variation in student learning and assessment. We know that students need support for them to be confident and competent. A lot of changes happened when everything moved from a national programme to approved education institutions. And that's when it all became a degree-only profession, and more universities are coming on board. There was quite only a few at first, but now there's more and more coming on board. The thing with that is every university has its own nuances, it has its own regulations, it has its own processes. And all of these actually have an impact, which I'm going to come on to for my next slide. But we also devolved assessment of practice to practice. That happens sometimes. And arguably, those who are doing practice, are the ones in the right place to assess students' confidence and competence. But then we look at how prepared and how able are student midwives when there's discussions around the short-staffed units, the vacancies, the pressures and the complexities that actually are taking midwives away from student learning, because they tend to, quite rightly, women, to ensure women are safe. And so therefore, where is the student in this? And of course, we need to ensure that these students have a robust assessment, because they're the ones that you will rely on as a colleague once they qualify. And they need to be obviously at a stage that you feel that they can do this. And what we're hearing is that students are not feeling ready. They're not feeling confident. They're not feeling competent. And that is a concern. If we're looking at different universities, and this is no criticism of universities, it is the system as is. But there are variables. So if we look at programme length of, say, both programmes, the long programme, minimum of 3 years is the standard. Doesn't say anything more than that. It used to say 3 years, 45 programmed weeks. It was really quite explicit. Some programmes are 4 years. Some programmes are slightly longer than 3 years, in between 3 and 4 years. So if you have a 4-year programme compared to a 3-year programme, that's an extra year of where students are being supported and nurtured, as opposed to 3 years. And when the new proficiencies came in, as an LME group, we did fight quite hard to make it a standard for a 4-year programme, because we felt what it needed because of what was included additionally in the new standards. KPMG conducted a survey, and students and practice partners voted against a 3-year. For all the obvious reasons. One is cost, but 2 is that they would take 4 years to get a midwife as opposed to 3. If you're looking at assessment tariff, again, universities for a 20 credit module have varying assessments from 1,000 words to 4,000 words. You know, to a viva of 20 minutes to an exam of 3 hours. It varies, but depending on the regulations and the assessment tariffs. Now, that is quite a big difference of what students can be assessed on, and also the robustness of the assessment. I'm not saying any assessment isn't robust. Please, I'm just talking about the variances. The staff-student ratio in universities, again, the standard was 1 to 10. 1 midwife teacher to 10 student midwives. Nursing was 1 to 12, health visiting was 1 to 15. That hasn't been the case for many years, certainly since 2009 standards, and there is now a variance across the UK. We've done this as a trawl, and also the RCM looked at the staff-student ratio with their freedom of information calls, and the variance can be as wide as 1 to 11, 1 to 12, to 1 to 38. So again, if you're looking at a teaching team that has 38 students to one midwife teacher as opposed to 11 to one in another, which students are going to feel more supported? How much more can you devote time and to visit clinical areas? That's a big difference. Again, units who have different staffing, they do brilliantly well, and I'm not saying that their students are any less of a midwife, but I'm trying to talk about the variations here. The interpretation of the standards, I can't recall how many discussions we've had about how you interpret the standards. Yeah, please come in. And obviously we're looking at things like hours, practice breaks, all of those sorts of things. 50-50 split pretty much. Some universities count practice breaks, some universities don't. That is actually quite a lot of hours that some universities are asking or not asking their students to have. And this is quite irritating for some students. I used to get criticisms saying that I'm paying for childcare and I'm paying for travel and all this for the extra weeks that students in university not far from us don't have to do. And I would try and say, but you are having the 40 hours. We'll try to divulge as to how, or dig deep as to where this came from. And I'm not unconvinced it wasn't from the short programme, because nearly every university did the short programme. Short programme students were employed, and if you're employed, midwives aren't paid for breaks, and so it carried on. And I think that's where it's sort of come from, and it's obviously crossed over to all programmes. Proficiency sign-off and preparation of our midwives for assessment and supervision varies. Standard is appropriate preparation. What's appropriate to me might not be appropriate to you or to anybody else. It's appropriate, so it's not regulated anymore, so therefore it's not approved by the regulator, and it's certainly not monitored. And so I feel that there is a disparity as to how some midwives are prepared and some midwives are prepared in different places. And then, of course, we've got staffing in units and we've got cultures, and that's all with the reports. So what we need is our newly qualified at the same level. Because what I'm hearing and what I was hearing was that our preceptorship programmes were different for different people. They had the standardised preceptorship programme, but when they looked at their newly qualified groups, they realised that some midwives were at different places to others. And they were therefore having to tailor their preceptorship programmes or extend it. That shouldn't be the case, in my view. A newly qualified is a newly qualified midwife. And so it's just something that needs to be considered. Quality assurance, again, I've talked extensively about this. Profound changes, I say, since we moved into universities, and changes in regulator. There is a variation, I've just explained, with student learning, assessment and experience. Obviously, programme approval and monitoring, and as an assurance of quality is that the approval and monitoring process is issued to another provider, which is now the Quality Assurance Agency. It is looking at the standards. So the root of everything is the standards. So if you are adhering to the standards, then it will be approved. But as I've tried to sort of explain, the standards can be interpreted differently. So you're still adhering to the standard, so you can't say you're not adhering to the standard, it's just being interpreted differently. And of course the monitoring. Now the NMC look at, because I've obviously talked to the NMC at length about the standards and the ambiguity when they've been party to a lot of our discussions. And they adopt what they call an outcomes-focused approach, as opposed to process-driven, which is what we had before. So outcomes-focused means this is the outcome we want. How you get there, you use the standards to get to that outcome. And therefore, it's open to interpretation. You're allowed to have interpretation. You're allowed to have flexibility. But is this causing confusion for students? Is it causing confusion for the clinical staff? Because if they have students from different universities that do things in a slightly different way, we have standardised the assessment document. It's quite cumbersome, but there's a lot of proficiencies to include in that. And we did, of course, change that, change the assessment, the supervision standards, and many went online, all during COVID. It was a little bit of a perfect storm. So I still think we are reeling from that. And then, of course, universities, is well documented, are in financial crisis. And that's largely due to lack of international students, European students, and the exchange and research. Because the researchers are predominantly collaborating with European universities, and the uncertainty of the funding and the future of researchers, they have left and gone back to their respective countries, taking the funding with them. And this has caused a problem. And so we know that there are swathes of redundancies across healthcare programmes. From personal experience, it's usually the higher tier, because you are the most expensive. And they are recruited, and then you recruit a lower band because they're cheaper. We used to have within the process standards exactly what you needed to become a midwife teacher. And you had to have a certain number of years experience, you had to have done your professional programme, which is the advanced diploma, and your teacher training in one of 5 institutions that was approved by the EMB, as was then, before you could apply to be a midwife teacher. That is not the case. And it is actually many junior midwives, and I say the teaching staff are brilliant, and they work so hard and tirelessly and do as much as they possibly can, but they haven't got the experience, many, or the expertise that you had to have or demonstrate previously. And there is no time limit. And experienced midwives are reluctant to take up lecturer posts because it's such a salary drop. It does not align with the Agenda for Change. It does compare unfavourably, and therefore it's a problem because we can't recruit experienced midwives. When I started, it was a big salary hike, very different. And then partnership working, which is critical. This is a 50-50 programme. Theory is assessed in universities, practice is assessed in practice. We have to work together. And yet, when I go back to the staff-student ratio, there are problems, because if you have somebody that, because if you have a high staff-student ratio, there is very little slack in the system. So if someone's unwell or something happens for some reason, and you were due to go in practice, you would cancel a practice visit because you would teach a classroom of students, quite rightly, because they've come in for a session. And it's usually the first thing to go, whereas before, it was actually in the standards that we had 20% of your time as a midwife lecturer spent in clinical practice. And so it was there, safeguarded. It couldn't be forsaken because you had to do it. So we need change. I'm talking about the rise in cesarean section and its consequences for staffing. There is, of course, the issue of the microbiome for the neonate, nature designed babies to come that way because of the bacteria. I'm not sure if this will happen, something at a later date, but it's an interesting prospect posed to me by someone who is very interested in that sort of thing. Obviously, looking at the midwife's role, statutory principles. We need statutory principles and processes to be put in place to safeguard the quality and consistency of programme delivery. And where and how students learn are assessed must be revisited. We need to have a consistent approach. We need to produce confident, competent, educated midwives that remain in a profession they are supported and equipped to be in. So that is my sort of parting, if you like, hope that we want. So, thank you.